you can't just tell a patient, take this medication and expect them to know the dose, the route, the frequency, and stuff like that. It would be crazy if we were physicians and said, take this. And they're like, oh, like, what do I do? But we do that with exercise so much. We say, like, you're overweight, you should run. But then you just feel like, is that appropriate that they made that comment to me? Like, can I even do that sort of thing? Like, how do I go about that?
Let's face it, exercise is good for the brain, right? It can help you think better and think more clearly. It can help with dementia, and it can be a treatment for depression. But how do we go about exercise in a way that's going to make it an effective treatment? How do we communicate that rather than just exercise more and being frustrated when it doesn't work? Well, Dr. Nick Fabiano is here to discuss that and talk about his new paper about how to prescribe exercise for depression. Now, first, a little warning though, is that we do have some discussions about suicidal thoughts and self-harm. So if you are triggered by that, just be aware. All right, so let's get on with this interview. Welcome to Metabolic Mind, a nonprofit initiative of Bazooki Group, transforming the study and treatment of mental disorders by exploring the connection between metabolism and brain health. Thank you for joining us on this journey. All right, Dr. Nick Fabiano, thank you so much for joining me today at the Metabolic Mind.
Well, thank you for having me.
Yeah, it's a pleasure. So we connected over Twitter, over X, where so many people seem to be connecting, I guess you could say. But I saw you post about a paper that you co-authored about how to prescribe exercise for the treatment of depression. I thought it was really interesting take about the how to. But so I want to get into that, about the why to prescribe exercise, how to prescribe exercise, talk all about it. But first, before we dive in, tell us about you. Tell us about your background.
So yeah, just a little bit about myself. So currently right now I'm based in Ottawa, which is in Canada, and I'm a third year psychiatry resident here at the Department of Psychiatry. And I have a particular interest in looking at, my overarching theme is kind of the overlap between physical and mental health. But when you kind of look a little bit more into it, I'm really interested in the lifestyle interventions. And by that, I mean things like exercise, diet, sleep for mental disorders. And this paper is about depression. And a large amount of my research is more focused on that because it's something that impacts a lot of people. But there are benefits across disorders. So that's kind of my main interest. So yeah.
Yeah, very good. I love that you're talking about lifestyle to treat mental disorders, because I think it's something that is easy to overlook, but yet has so many potential benefits. So your paper that caught my attention was the how to prescribe exercise for depression. But let's take a step back and say, why are we prescribing exercise for depression? So, I mean, I think people intuitively get, like, exercise usually makes you feel good. Maybe you're outside breathing fresh air, you're moving your body, you're blood pumping, you can get endorphins. And there seems to be sort of a body of literature that exercise is just good for the brain, whether it's for cognitive function, depression, brain fog, and others, right? So, and even dementia. So what do you see though as the strength of the evidence, and give us a little bit of the background evidence suggesting why exercise is good for depression?
Yeah, so that's a great question. So in psychiatry, when we're looking at tackling something like depression, most of the time, the two conventional pathways that you can take are things like an antidepressant medication or therapy, and they're not mutually exclusive, but as it's taught throughout medical school and even in residency, oftentimes those are really the only resources that are the first line sort of things. And oftentimes we don't look at lifestyle stuff, and a lifestyle, again, mentioning things like exercise. So I became very interested in looking at kind of the exercise thing because it's very unique where exercise can treat both the mental and physical side of things. We know that people with depression, there's a bidirectional association with physical ailments. So, for instance, someone that has depression has a higher chance of having something like a heart attack. And the same thing as someone that has a heart attack may have a higher chance of developing depression. So, from that basis alone, it really sparked that interest of, could we use exercise as a method to treat the depression, but not from the same lens as we traditionally do in psychiatry when we look at things like treating with a medication and assessing the outcome. And then the same thing with therapy, but instead to kind of do both at the same time. The other thing with that as well too is with a lot of our treatments, so antidepressants and stuff, a lot of them have some metabolic burden to them as well too. And by that I mean things like weight gain, and glycemic control issues. And oftentimes, when we're treating patients and we're just seeing them in one instance, we don't really address that with them. Maybe we speak to them about it very briefly, but I think it's important to incorporate something else, again, as I mentioned, that can help deal with maybe some of these side effects. So that's where some of that evidence is. And to get more into where is the evidence right now for treating depression and how does it compare is another question that often people ask to antidepressants or therapy, which again, as I mentioned, are kind of the first line. Well, if we rewinded years and years ago, people would be like, you're crazy to try to treat depression with exercise. But in the recent years, there's been more and more and more studies looking at movement essentially as medicine for mental health. And there's been a lot of different meta analyses, different umbrella reviews, which are essentially things that group studies together that show that exercise is actually very comparable to things like antidepressants and therapy. And when I say comparable, I mean from an effect on the depression. So in these studies, they look at before and after treatment to see how these depression scores have decreased or if these patients have went into remission. And when we take all of these studies and put them together, we actually see that they're quite similar. So across the board. And the other thing to say is that that doesn't mean that these treatments are necessarily the same, because as I mentioned before, a lot of the side effects that something like antidepressants might cause can be treated with exercise. And then the other important point to address too is that these treatments don't have to be used in isolation. So oftentimes, when people feel that you're in the exercise camp of stuff, sometimes they assume that that means that now I can't use medications or I can't use therapy. But there's evidence to show that there's a synergistic effect. So you're using all of them together to improve those outcomes, which is why I think it's really important. And I think it's also important to give the patient the option because sometimes if you're only given two options, so antidepressants or therapy, that might not be feasible for the patient. It might not be something that they're motivated to do. The side effects might be too much. So even if it's not something that everyone wants to do, that's completely okay. But I think it's important to expand the options that we have available to offer our patients so that at the end of the day, they can make an informed choice with regards to that treatment. So I hope that's a little bit of an overview of some of the antidepressants, effects of exercise, and stuff of that sort.
Yeah, I think that's a great overview. And I think it's also worth emphasizing that we're not talking about studies that just observe people who exercise more have less depression and people who exercise less have more depression, because then you don't know cause and effect, chicken or the egg. But these are actually
Mhm.
interventional trials where they, half the group gets an antidepressant, half the group gets exercise, and they tend to do equally as well at the end of the observation period. Now, not maybe every study, but like you're saying, the meta-analysis show
Mhm.
in the end, like on par, that they do the same or better. So, would you agree without putting words in your mouth, that it is these interventional trials that we're talking about?
Yeah, so it's at the yeah, like you mentioned, the interventional or like otherwise known as like the RCTs or randomized control trials. And with those, the important point to note is too, oftentimes it is stronger evidence than like you mentioned, observational studies where you're kind of taking a third person view and kind of seeing what's happening in people that are more active. And they're very vulnerable to confounders at that point, which is why this higher level of evidence is important. But at the same time, it doesn't go without its limitations. And if it's okay, maybe we could talk a little bit about that with the evidence and limitations of using it and basing stuff based on RCTs. The first thing with RCTs or randomized control trials is that they're often very small. It's helpful when you bring them together and put it into meta analysis. You get these sample sizes that are now in the thousands, which is better than when you're in the hundreds, or even some of these trials are very small in the tens or 20s. But the other times, it's not always representative of the general population. So sometimes these RCTs pre-select for populations that may be healthier or maybe younger than the patient that you're treating, which is important when you're trying to apply those findings to the patient in front of you. And then the one main critique of exercise research is the fact that it's very hard to blind someone to the fact that they're exercising. You can't blindfold someone and make them run because they still know they're running and stuff like that. So it becomes very difficult because that does influence the expectancy effect, like knowing that you're exercising, knowing that your body's moving. And it's hard to compare that sometimes to trials compared to like antidepressants, where if you have a placebo pill, you don't know if you're getting the active drug or if you're getting the antidepressant, and it's easier to blind at that front. So one of the largest critiques of exercise research right now is that inability to effectively blind, and it's a tough obstacle really to get around. But stuff that is something that you need to acknowledge, but doesn't completely take away from how important the research is.
Yeah, that's a great point about the blinding. And I guess devil's advocate would say, like, so what? Who cares? If the patient's getting better, it
Mhm,
doesn't matter, right? So there is that
mhm,
approach too. But you're 100% right that
mhm.
it does sort of weaken the higher level of evidence for the RCT. And I guess the other thing that rolls into the randomized controlled trials or the interventional trials, like you said, the population selected, and I guess that's where depression really deserves sort of some discussion, because depression is a diagnosis by itself. But if you're talking
Mhm.
mild, moderate, or severe depression, major depressive disorder, the etiology and the effect of an intervention may be different. But also, depression can be a symptom of so many other, DSM-5 so-called illnesses, whether it's OCD or anxiety or even bipolar disorder or schizophrenia. Like, depression can fit into all of those. So does that complicate things in your mind when you say, how are we treating depression, and what depression are we even talking about?
No, that's a really good point you bring up, and I think that applies across different psychiatric diagnoses because where we are in psychiatry, as you mentioned, is a lot of times, and we'll keep it to depression. It's a cluster of symptoms, and oftentimes, as you mentioned, they can be present in a variety of disorders and disorders that aren't even what we would deem to be a mental or psychiatric disorder. So it does cloud that picture a little bit. But sometimes it's helpful rather than treating based on the DSM definition or anything of that sort. You kind of look at the symptoms you have, see how you can treat that and improve that patient's quality of life. Because otherwise, the overarching picture becomes very, as you mentioned, confusing and very kind of all these gray areas of what is depression. At the end of the day, it's just symptoms that we put together that we said you need to meet this criteria for X period of time, these number of symptoms. But say you're one off of having a major depressive disorder diagnosis, I would be in the camp that that doesn't take away from the experience that that person is having. And still, there could be benefits to things like exercise. But you're right that it clouds that picture a bit. And you mentioned something as well too. So grouping depression into the mild, moderate, and severe, and that's a very important point as well too, because sometimes where people get stuck on is that a lot of the depression research is mostly focused on the mild and moderate depression. So those are people that have these symptoms. They're still able to function oftentimes in their daily life, but it's not easy. They feel very fatigued. They can't concentrate. Maybe their appetites change, but they're still able to go to work and do these sorts of things. But when you're looking at a more severe depression, someone that's bedbound, they're not eating, they're not drinking, they're completely shut down. The concept of exercise in that instance, it may not be fair to apply that to that person, and not indefinitely. That person, I would hope isn't going to be severely depressed for their entire life, but perhaps there's a time period where it's appropriate to introduce exercise. And again, going back to it, the research that I discussed before, almost all of it is exclusively on that mild to moderate depression, where you see that the patient is maybe able to engage a little bit more, or maybe exercise is appropriate, but also to say that it isn't appropriate for everyone, not only for kind of a motivation perspective, but also there can be physical ailments. Like if someone has an injury, or if they have a pre existing medical condition, that doesn't mean that they can't do any exercise at all, but it becomes important to apply a unique exercise prescription to that person, whereby you don't just apply, this is what the guidelines say, this is what you should do. If you can't do that, then I don't know, sort of thing. It's important to very much personalize it from that sense. And I think it's a great point that you brought up the mild, moderate, and severe.
Yeah. And to harp a little bit more on this, why are we using exercise for depression or for mental health or for brain-based disorders? A lot of times medicine wants to know the one mechanism, right? The
Mhm.
GLP-1 drugs, they work because they are an agonist for this GLP-1. Although we have
Mhm.
to admit there are some drugs that we have no idea how they work, and some drugs we say have one mechanism, but really can have multiple mechanisms. But with exercise, it's a lot more complicated, right? It's
Mhm.
hard to say there's one mechanism, and you already brought up the metabolic health part of it. And in Metabolic Mind, we talk a lot about this connection between metabolic health and mental health. So anything that's going to improve metabolic health is likely going to improve mental health. So that certainly could be one of the mechanisms. Is that the only mechanisms, or are there others that have been proposed and studied about how exercise helps
Mhm.
brain-based disorders, how it helps symptoms of depression?
Yeah, so I think with regards to that, it's almost important to take one step back from that question first. So to first ask, do we even know the mechanism for depression? And the answer to that would actually be no. We oftentimes look at it, and the long-standing thing was the serotonin hypothesis, and saying that there's just a deficiency in serotonin, and that was the rationale for some of our medications that we use right now. But the reality is it's much more complex than that, depression as itself. We don't even know the mechanisms behind that. We do know that there are changes in neurotransmitters, so things like serotonin, norepinephrine, dopamine, but we don't know if that's necessarily causative. And by that, I mean, we don't know if those neurotransmitter changes is what caused the depression or if that was a result of the depression. And then there's a million other factors that can kind of go into the biological side of depression. So we know that inflammation can contribute to it. We know that a bunch of other different factors from that side. And one thing that exercise is known to improve beyond the metabolic side of things is there's something called the brain derived neurotrophic factor, or BDNF. And exercise essentially is able to increase that. It's like what we call the miracle grow for the brain. And that's one of the supposed mechanisms. But I like to discuss a few others because oftentimes we get very entrenched in the biological side of things. But I think it's important to look at the biopsychosocial, so a three-pronged approach of how exercise might help. So we've spoke about biological, and there's much more to speak about beyond that. But I think for all intents and purposes, before we get down a specific pathway and all that, I think it's a good start. But when we look at exercise from a social perspective as well, too, oftentimes when you exercise, you may be on a sports team, you may be going to the gym, you may be exercising with friends. And this is often an overlooked part of exercise as well, too, the social aspect, particularly in older populations too, where you have during the COVID pandemic where people are isolated, they live alone, maybe they're widowed. And going out to exercise might be the only social interaction that they have for the whole week or something of that sort. So that part is very important to consider. And that goes into the psychological side too, as we briefly touched on in the beginning too, with the immediate benefits on your mood, your self esteem, your ability to tolerate stress. I think all of these come together for the antidepressant effects of exercise, and it's a very complex picture. And oftentimes in medicine, we try to simplify stuff to make it easy to understand, which makes sense from a teaching perspective. But I think we're such early days in not only exercise mechanism, but also depression mechanism, or defining what depression is, that it's impossible right now to say what the mechanism or single mechanism for exercise may be, or even depression. But I think all is to show that we see these benefits. We know that there are some things happening, and we're only building our knowledge day after day. So we'll continue to see growth from that area. But for right now, there's not a clear answer.
Yeah, such a good point about the mechanism of depression and taking that step back and how we do like to simplify things. Oh, okay.
Mhm.
An SSRI might help, so it must be serotonin. Case closed.
Mhm.
Why dig
Mhm.
any further? Yeah, so not doing ourselves any favors by being so
No.
simplistic. Yeah, but and then sort of like I said before, again, devil's advocate or just oversimplifying things. Like, who cares? Who cares why it works if it works? And I think a lot of the times, searching for the mechanism is so we can create a pill that does the same thing as opposed to just doing the thing. And I guess
Mhm.
part of that is because, clinicians and have maybe become jaded about, I could talk to this person about exercise, but they're not going to do it. Nobody sticks to
Mhm.
it. So why be, like they've just been jaded over time, but maybe they're just not doing it right themselves. Maybe they're not given the right coaching, or maybe, there needs to be more accountability and support and so forth. So that's when we get into this how. How do you
Mhm.
prescribe exercise? How do you discuss exercise so that someone's going to use it, stick with it, and see the benefits? And there's a lot to consider. What exercise, how much, how intense, how often. So how did you sort of start to synthesize all this for your paper?
So it's a great point with regards to the medication because in medical school, as a physician, we learn to prescribe medications oftentimes. And with medications, you can't just tell a patient, take this medication and expect them to know the dose, the route, the frequency, and stuff like that. It would be crazy if we were physicians and said, take this. And they're like, oh, like, what do I do? But we do that with exercise so much. We say, like, you're overweight, you should run. But then you just feel like, is that appropriate that they made that comment to me? Like, can I even do that sort of thing? Like, how do I go about that? So it's very similar, the two. So prescribing both a medication or exercise. And I think speaking from my own experience and speaking to other people that have been through medical school and are residents or physicians now, we're oftentimes taught that exercise is so beneficial in mental health, but also in physical health and that whole thing. But it's oftentimes just exercise. It's not anything beyond that. We don't learn which types, we don't learn which how to prescribe that for a different population. And I think that's where this paper came in to hopefully provide somewhat of a framework that clinicians could use to have a conversation with their patients because oftentimes there's previous research to show that if a physician themselves isn't active, they're less likely to talk to their patient about things like this because that probably represents a lack of knowledge in the area. And that's okay, right? Like, I don't expect every physician to have to exercise and do this thing, but I do hope that they would be able to have a discussion with their patient if they were interested in it. So that's what brings up kind of the framework for this paper, which was the FITT principle. And this is something not that I came up with myself. It was from a previous literature from the FITT. But it breaks down a similar prescription to how you dose the medication. So the F being the frequency, so that's how often you exercise. The I being the intensity of the exercise, and that's separated into the low intensity, moderate intensity, and the more kind of vigorous intensity. And then you get into the type of exercise. So that's something like, is it aerobic? So something like running. Is it resistance? So that would be like weight training. Or is it something that's mind body, something like yoga? And the last part of it would be the timing of it. So how often are you, or sorry, timing of it would be how long are these sessions? Like, how long do you want these sessions to be? And maybe we can kind of talk about going through that framework now and kind of with the recommendations of this paper and then kind of discussing from there. And we've made some recommendations in this piece in terms of how what would be quote unquote optimal, but at the same time it's as I mentioned before, not fair to apply across different patients and different things like that because everyone's unique. So it's a reminder that this is a guideline, it's a framework, but it's not something to be followed to a T. It's a great goal to set, but it's not necessarily necessary. And it's based on the evidence in terms of where we've seen benefit from depression based on these intervals. So to start with F again, to go through for frequency, we found the most benefit for 3 to 5 sessions per week. The intensity of the exercise was usually more in the moderate to vigorous. So the higher the intensity of the exercise, the greater the antidepressant effects. But there are caveats to this as well too. So particularly in older populations, we actually find that the low moderate is actually more effective in treating depression. So it's important to keep in mind these nuances as well too. And the other question you're probably asking is like, what separates these intensities? Like, how do I know? Do I wear a watch that tells me I'm at this specific rate? And if you want to get really into it, you can look at heart rate and different things like that, comparing it to your max heart rate. But the simple thing that I tell to patients is to do the talk test. So if you're able to have a full conversation, you're able to even sing while you're exercising, you're probably at a low intensity. If you've upped the intensity a little bit and you're able to now still talk, but you couldn't sing a whole song or something, you're putting in some work. You're probably at a moderate intensity. But if you're going so hard that you can't even have a conversation with someone, that's probably more in the vigorous intensity. And that's a good mental way. It's not perfect, but it's probably more feasible than having to track your heart rate and all these VO2 max and all these different stats. Um, and then the other thing is the time of the sessions. So oftentimes we recommend sessions that are 45 minutes to 60 minutes. But at the beginning, maybe that's not feasible. Maybe not doing that much is realistic. So doing shorter sessions or any exercise is better than none, is what we say. And then the last part I mentioned was the type of exercise. So as I mentioned, that can be aerobic, strength, it can be mind body. And the literature is a little bit all over the place in terms of which one is the best. Sometimes aerobic comes out a little bit on top and then strength, mind, body. Sometimes they flip flop depending on how they synthesize the evidence. So, what I would recommend there is that whatever one you want to do, because the biggest factor beyond the fit principle is adherence. And the same thing goes with diet. You can have this diet that you can follow for a week, but you absolutely hate it, and you're going to just drop off and stop it after a month or a few weeks, and you're not going to see the benefits. So the biggest principles beyond these overarching principles is any exercise is better than none, and you want to do something that you want to do, not something that you're necessarily forced to do. And it might not be fun right away. Like it might take some time to get into and find that you enjoy it, but it's important to work with your doctor or whoever you're working with to kind of really find what works for you as a patient.
Yeah, such a good description and bringing in the analogy of nutrition, and so much more complicated than take this pill twice a
Mhm,
day and, see you in 6 months, right? So much more
mhm,
complicated. But that doesn't mean we shouldn't be talking about it and shouldn't be doing it. And I love how you brought up that if the doctor themselves does not exercise, they're less likely to recommend it. I mean, I think everybody in medical school should be required to become a certified personal trainer too. I took the
mhm,
personal training course. I know some other physicians who've become certified personal trainers, and not that I work as a personal trainer, but I can speak the
mhm.
language and I know how to recommend it to patients. I think everybody should do that, but that's my little soapbox aside. Before we continue, I want to take a brief moment to let our practitioners know about a couple of fantastic free CME courses developed in partnership with Bazooki Group by Dr. Georgia Eid and Dr. Chris Palmer. Both of these free CME sessions provide excellent insight on incorporating metabolic therapies for mental illness into your practice. They are approved for AMA Category 1 credits, CNE nursing credit hours, and continuing education credits for psychologists, and they're completely free of charge on mycme.com. There's a link in the description. I highly recommend you check them both out. Now back to the video. Um, but so you're talking about what the recommendations are, and you mentioned the word optimal. What's optimal? And I think a lot of people are like, okay, but what's like the minimum to do to get some benefit, right? Everybody wants to know what's the least amount I can put in to get some benefit. And you made the
Mhm,
comment that some is better than none, and
mhm.
then there's the optimal level. But is there sort of like a threshold? Like, if you're not doing it for 15 minutes, don't even bother, or even getting up and 5 minutes of walking, like even that's going to do something. Like, where do you stand on that?
Yeah, so there is some research into this, and again, falling onto the meta-analysis, bringing stuff together sort of thing, and it's based on RCTs and different data from that side, but it still stands by that principle of any exercise is better than none. So when you look at the curve in terms of, and I don't have the exact numbers off my head right now, but when you look at that curve, even little bits of exercise are so beneficial, and it's those little bits that helps so much at the beginning, and then you start getting a diminishing return when you're doing more and more sort of thing. So the argument would actually be that if you're able to do a little bit, the more and more that you can do, you're really going up and having that antidepressant effect. So if you compare someone with no exercise to just a little bit, there's a big change even. And then just a little bit more than that, there's a big change. And then it keeps going up from there. So when we're chasing these like optimal levels, sure, it does improve it and improve, but you can imagine that if you're feeling depressed, you're sitting down all day, you're not doing anything per se, and not because you don't want to, because you just can't, like you don't have that motivation, that if you're able to get into things and maybe just go for a walk and maybe even things like just get up, leave your apartment, go up and down the elevator, come back up. That movement is so important compared to none. And it leads to those further changes. It leads to that motivation that you can do more. It leads to the motivation to want to do more, or that things aren't that scary and that you maybe want to look into this or have that conversation. So I don't have an exact cutoff in terms of how much is meaningless per se, but anything from that curve is helpful, and it only gets better and better as you're doing more.
Yeah, I think that's a really good perspective. And just starting with some doesn't mean you stop at whatever level you're at, but you build it from there. And having sort of short, obtainable goals that, the stepping stones to get you to a larger goal are so important. But you mentioned the point of diminishing returns. So at some point, putting in more time and more intensity may not have the same level of psychological benefits, I guess you could say.
Mhm.
But yet there are some people who find, extreme amounts of exercise is what they need, so there's definitely outliers.
Mhm.
So what does the evidence say about that? The ultra marathon runners, the people who are doing far more than what would be considered normal.
Mhm.
But yet for them, that's sort of what they need to scratch their itch, or that's what
Mhm.
helps them from their mental health.
Mhm. So that's a great point. Like again, with these things, everything is just kind of a guideline from that front. So as you mentioned, there are people that maybe they do better with a lot more, and there isn't that kind of point of diminishing returns. And I think it's really on that patient by patient basis and having that open conversation with them. But I think that leads into an interesting point as well too, where and something that I've written about recently about sometimes exercise may be perceived as a form of self harm. So, to kind of explain the situations, we've done two previous systematic reviews on this topic, looking at exercise, not the effect on depression, but the effect on suicidal ideation. So, that means thoughts of suicide, suicide attempts, and then also deaths by suicide. And what we found in both of those studies was that exercise led to a modest reduction in suicide attempts. Didn't change the actual deaths by suicide or the ideation part, just the attempts, which is interesting. There's a lot of nuances, might be because of sample sizes, et cetera, et cetera. And originally, we hypothesized that it reduces attempts because exercise is able to tailor or dampen one's emotional impulsivity. Because we know that a lot of suicide attempts are actually characterized by impulsivity rather than something that's well planned out and someone that has a plan that they're going to do. Um, so from that, that's kind of what we went with. And then I was thinking, like, what if there's something else going on? And that brought up the concept of can exercise also be a form of self harm? And not all the time, but to explain it, self harm isn't always with suicidal intent. Sometimes people feel very emotionally overwhelmed, so they can resort to things like cutting or burning. And those are more of the traditional self harm things that you've probably heard about. But there becomes the concept of people that may use exercise as a maladaptive coping skill where they're exercising to feel that pain or to cause an injury, even. And that's where sometimes you see these people that are exercising a lot and a lot, and it seems like it's working for them at a surface level because, from a societal perspective, we see that as sublimation or someone has positive coping skills to a stressful stimuli, which may be true. But at the same time, I think it's important that if we're seeing someone that's having so much exercise that they need to sustain themselves to have these antidepressant effects, perhaps opening that discussion to seeing, is this a form of self harm? Is there an underlying depression that isn't necessarily being treated, but it's being successfully coped with through exercise, perhaps as a method of self harm? And I think that's an area that's very new. There's not a lot of research behind it. But when I did write that piece, it resonated with a lot of people, which was very interesting to see. So I'm hoping to see more research in that area. But for now, I think it's an important concept for clinicians also to be aware of exercise not only as a form of self harm, but also exercise dependence, where people need to exercise, which has a lot of comorbidity with different mental disorders such as depression.
Yeah, I was going to ask you about the response that you got in writing that because I could see how it could be very controversial and
Mm.
people could be very critical of it, and even sort of calling it self harm, but in a way it's almost like adaptive, so that you're not doing other forms of self harm. So the term self harm is sort of misleading because it sounds so negative when it actually could be fulfilling sort of almost a positive role. So
Mm.
yeah, tell me more about sort of like the feedback and the response you got from people after you wrote that.
Yeah, I think it surprisingly had a lot of positive feedback because I think a lot of people, although as you mentioned, the more traditional methods of self harm, where again, someone might be cutting or burning themselves and leading to visually damaged parts on their body or something that is more what we conceive to be self harm, it resonated with people that may not be doing those acts, but maybe using exercise again as that coping mechanism, which again, it can be a good thing if it's replacing those. But at the same time, it received that response because people were realizing, like, hey, maybe I am having a hard time. Maybe on a societal level, people are saying, you're going to the gym and going so hard all the time that you're passing out. You're like, wow, that's a hard worker sort of thing. And it reinforces that. And it almost leads to this hidden subgroup of people that are suffering. But from a societal perspective, it looks like everything's okay because they're using, as you mentioned, these positive coping skills, which I do think it's good to use things like exercise and use this as a coping, but also to be realistic with yourself. And sometimes coping skills don't get to the root of the problem. And as we've been speaking about this whole time, like exercise can be helpful in treating depression. It's not always perfect. Sometimes you do need other things to help as well too. So I think it really resonated with the people that kind of had that moment where they took a step back and said, "Am I doing this to cope, or is this something that's helping me?" Um, And it opened that discussion and hopefully led to further discussions and the help that they needed.
Yeah, yeah, super interesting. And I want to circle back then to something you said about maybe it's not, they need more than that, and it's not all they need, and it's not always a solitary treatment. So when we talk about nutrition a lot, which we do at Metabolic Mind, there are sort of two ways to look at it: nutrition instead of medical therapy, which is how a lot of people look at it. But by no means is that really what the majority should be. It could be,
Mm.
synergistic and working together. And you mentioned that word earlier, that exercise plus medications is often synergistic. But at the same time, some people may choose to use it as a solitary treatment without medication. So how do you sort of help people understand where exercise fits in terms of using it by itself, using it with medications? Can it help, taper medications, et cetera? Like, tell
Mm.
us a little bit about that.
Yeah, so with that, I think the principle that I follow the most is as a physician, my role is to educate the patient in front of me in terms of their treatment options. So in the case of depression, whether it's exercise, medications, therapy, and what that looks like. So commitment wise, side effect wise, time wise, and really working with the patient so that I feel that they understand all of the options and kind of going the route that makes the most sense for them or their schedule or what they're hoping for. And I think that's where you'll get the most success too, because exercise, although it seems positive, can be quite a polarizing topic sometimes. And it can be very off putting for patients that have had bad experiences before, where they go, for instance, maybe to their primary care doctor and they're just repeatedly told to exercise, exercise, exercise. And they're not doing it because they weren't given the instructions. So that term exercise now being said by their psychiatrist can be so off-putting because maybe they felt like it was a safe space and mental health has nothing to do with that sort of thing, or that's the notion that they had. So I think the best approach is to make sure that you're giving that educated opinion. So describing the things that we spoke about, that exercise, antidepressants, and therapy have very similar efficacy independently, and then together can be used and be very helpful. Because you can imagine something like a complex trauma or something that led to a depression. Exercise alone might not solve that. Exercise might help stuff be easier. You might be able to deal with those stressful situations easier, but therapy might be needed to be able to talk about those things because you can exercise as much as you want, but if you're not really unwinding those memories or what happened, it's important to get all of those modalities together. And same thing with medications too. Like if somebody is open to having that and having that synergistic effect, but is also aware of maybe some of the side effects that are associated with antidepressant medications, it's important to have that informed discussion. So I think, in summary, each of those treatments has their utility, both alone and together. But it's ultimately up to myself as the clinician to educate them, for them to make that decision, and for me to do my best to guide them through that. And the other thing is, too, I think oftentimes patients think like, when I make this decision, I have to stick on this one and just this one alone. But say you decide to do antidepressants first, that doesn't take exercise off the table. It doesn't take therapy off the table. You can do a stepped approach as well too. So, and I don't think that there's any correct order per se too. Even though I'm a big advocate for exercise, I'm well aware that it's not for everyone. Maybe they don't want to do it, and the timing part comes in too. So, as I mentioned with regards to severity of depression, if someone's severely depressed, maybe it's not even correct to offer exercise as an option right in this instance until we're able to get them to a point where they're feeling a little bit better. And maybe that's something they're considering. But again, the overarching thing is just informing the patient and allowing them to make that informed decision.
Yeah, and it's interesting how you brought up the specific example of the trauma and needing therapy, and I could see some patients reacting like, "Wait a second, I thought my depression was because of my chemical imbalance and my genetics, and now you're telling me it's my fault because I didn't exercise." Like I can sort of see that type of
Mhm.
reaction. Have you come across that
Yeah.
response?
No, 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 for sure. And I think that's a very common thing and why there's sometimes that immediate pushback to exercise. And I think for both exercise and diet, it's important to frame it in a specific way to the patient. So to avoid that kind of response, because it can be very off-putting for a patient where it feels that when you're a physician and you're in that position of authority, you're almost, sometimes patients can be feel that they're being spoken down to, or that, as you mentioned, that they caused their depression. But when this happens, it's important to look at depression or any mental ailment to kind of be similar to a physical disorder. So someone that has asthma per se, you didn't ask for it, you didn't want that to happen, you didn't necessarily cause that, But then to say that, hey, these are some treatment options that would help. You don't have to take them. It's not something that you caused or anything, but I want to be here as your physician to help guide you through that, provide you with the support, the education, and follow you along the way to make sure that you're as successful as possible at that. And if the patient says, hey, like I'm not open to that right now, and leaving the discussion there, but just letting them know that the door is always open to have that conversation again, I think is the best approach to avoid that accusatory or overwhelming stance of kind of shoving exercise down someone's throat and if they don't want to.
Yeah, the other important part about knowing human behavior and behavioral change, and that it's
Mhm.
hard, and that not everybody responds the same way, and how to go about it in an individualized fashion. But before we wrap here, the other point is, which you brought up earlier, about the metabolic consequences of both having depression and the medications for depression, or if you're talking about medications for schizophrenia or bipolar disorder, they are just ripe with metabolic complications, with insulin resistance, with weight gain. So of course you want to use exercise as part of a treatment for that. And oh,
Mhm.
by the way, may also help the underlying mental disorder as well. That's sort of how we look at nutrition and ketogenic therapy and metabolic therapies. Like, it can help with the metabolic consequences, and oh, by the way, might help with the psychiatric consequences as well. So
Mhm.
it's a twofer. So why wouldn't you? And so it's like such an obvious approach, but as we've talked throughout this interview, it's not easy. It's not straightforward, and not as easy as the pill. So that's why I'm so thankful that you wrote that paper about how to discuss it. So it's not just beating somebody over the head, exercise more, exercise more, exercise more, and it becomes this self-fulfilling failed prophecy, but giving some advice and giving some direction. Yeah, so thank you for writing that. I appreciate that. Hopefully more people will see it and learn from it, clinicians and individuals, because you can apply it to yourself or you can apply it to your patients. So what's next for you? What else do you have in the pipeline that we might see from you in the future? And then finish that up by telling us where we can find more about you.
So yeah, I think thank you again for all the compliments with regards to the article. I'm glad that you found it helpful. And in terms of what's next, like I mentioned, I'm still very much interested in the space of exercise, diet, and sleep. And as I mentioned, I'm still just a third year resident now, so I'm still working on kind of building those skills. I'd say right now my higher knowledge base is in the exercise realm, but I'm working on building my knowledge in the diet and sleep realm as well too, because towards as I go on with my career, I'd like to have those three main pillars and kind of work on those and incorporate those in different ways. So, in terms of next, I think I'll have a lot of different studies on exercise coming out. We're looking more into, as I mentioned, the exercise as a self harm piece, and more so than the opinion, but looking into more of the evidence. And if the evidence isn't there, getting that evidence. So that's some of the next steps. And again, building upon my knowledge from the diet standpoint and the sleep standpoint to really put all these together, because how I envision what my practice will look like in the future is going to be putting these things all together to be able to help the patient that's in front of me. And that will require some learning and different things, but maybe in the future I'll have a paper of how to prescribe diet for depression or something like that. It's not in the works right now, but something I can certainly see across disorders as well too, because there are nuances that are important to discuss. So again, thank you for having me. Right now, if you want to find me on any platforms, I'm pretty much just active on Twitter or X, and that's at NT Fabiano. And I usually post kind of scientific articles there. It's not always exercise related, but I usually just break down articles into, I try for about 10 tweets, so that the convoluted knowledge of science can be in a way to understand a little bit easier. But yeah, thank you for having me.
Yeah, my pleasure.